proceed.
Okay, thanks, Bob. Hi, everyone. So I'm Maria, and together with Talia and Matthew, we did the presentation on discharge summaries and evaluators. So discharging a patient from a hospital or even a casualty setting has traditionally been the role of chief doctors, and in our setting, that is the interns. A discharge summary is a clinical report that is, sorry, this is on this. Sorry, Paul. Oh, there we go. No, back. Okay. So a discharge summary is a clinical report that's prepared at the conclusion of a hospital stay or a series of treatments. It's a legal document, but unfortunately, the importance of these documents in our setting seems to be underemphasized. Possible reasoning for this is that the training that interns especially receive is dependent on the institution in which we are working, and the quality and amount of training is, of course, variable. More often than not, there is insufficient feedback and supervision given on how to produce high quality discharge summaries. It looks like, looking at the different literature available online, that errors with discharge summaries are a common occurrence globally. In a study that was done by the Royal College of Physicians in 2002, it showed that 17% of discharge summaries had no diagnosis, 19% had no information regarding tests or procedures that were done, and 21% had no details regarding follow-up care for these patients. A more recent literature review that was published in 2017 in the Journal of the American Medical Association further emphasized the important data that's perhaps erroneously omitted from discharge summaries. The primary diagnosis was omitted 17.5% of the time, which is concerning because it matches the study done in 2002, which was 15 years prior. 21% of the summaries had no medications at all that were listed, and 65 of them had the pending results not being included. So what we are going to try and do today is maybe give a succinct example of how to write a quality discharge summary. As mentioned, the greatest barrier to having a well-written, concise, and informative one is the lack of standardized training and insufficient feedback and supervision. Now, in our settings, we are quite fortunate because our discharge summaries, while they might differ in the institutions, they all follow a nice format form, so it's quite easy to fill them out. They have these 6 points that are imperative to be mentioned: the details, the reason the patient presented, the past medical history, all the significant findings and what was done for the patient while they were admitted, as well as complications, education provided not only to the patient but the family as well, the follow-up care plan, and medications. So what you see here is the discharge summary that most of us are accustomed to having. And as you can see, it is very clear what information is required. I think where some difficulty lies is how much information to put and how relevant the information actually is. So first up, looking at the details. If you look at the discharge summary, the details of the patient, the physician or the doctor, the location in which the patient was admitted or received care, and the details of the discharge status are imperative to be mentioned. So I'm going to break this down into smaller categories. So first, we've got the patient details. This normally does appear on the patient sticker, as you can see in the bottom right of the slide. If there's no patient sticker, you need to ensure that the full name, date of birth, sex and gender are included, as well as the ID or hospital number. Important as well, you can put the safety alerts, for example, if a patient is a Jehovah's Witness, or if the patient has any significant allergies like ACE inhibitor allergy, and then the next of kin or emergency contact. But of course, most places do have patient stickers that cover these details. The doctor's details, again, is quite self-explanatory on the discharge summary, but these may differ. You put the name, the qualifications, and registration number, as well as the contact number and the signature. Then the hospital, usually the hospital's name and contact information or address are included on the discharge summary or otherwise on the sticker. You need to mention which ward or speciality was caring for the patient during the admission, who the head of that department was, when the patient was admitted, when they were discharged, and the time that they were discharged. And at the very bottom of the discharge summary, this is something that's quite often left out. It's the discharge destination and how the patient actually was at the time of discharge. Next, we have the reason for admission, past medical history, and final diagnosis. So on the discharge summary that we are usually provided, it's very little space, so you need to ensure that the information given is concise and relevant. The reason for admission is dedicated to communicating the story associated with the patient's hospitalization. So how did the patient present? What was the key history that provided clues to the diagnosis and severity? And were there any events that affected management during the course of hospitalization? Then we have the final diagnosis that needs to be as accurate and as clear as possible. So for example, a cough is a symptom, but was the patient ultimately diagnosed with like pneumonia, bronchitis, or a COPD exacerbation? Then the past medical history is also referred to as secondary diagnoses, and here you just need to mention what is pertinent in providing comprehensive care for the patient. The significant findings and procedures, again, quite a small section. It's not necessary to list every test that was performed for the patient during hospitalization. As mentioned in the title of the slide, only significant results should be reported. So, for example, it's not necessary to report the daily chest X-rays of a patient intubated in ICU with a pneumo, but you would, for example, need to mention the most recent UNE result for a renal failure patient. It's also important if you are discharging the patient and you've any tests on them on the day of discharge to add barcodes so that future practitioners can look up these results if you're not available. Mention a small comment on any complications if there were any during the hospitalization, the treatment given to the patient, and the services provided. So if any of the allies were called in managing the patient. The education and follow-up care plan is right at the bottom of the discharge summary that we're used to. And this needs to be a biopsychosocial approach. So here you ideally want to educate both the patient and the family in improving their health-seeking behavior and management of any chronic conditions. So this section is used as well to convey what is needed to provide continued care, which could be as mundane as checking the potassium in a week to requiring CT chest in 3 months to follow up a lung nodule. Also a very important part of the discharge summary. And finally, it's the medications, and the list that is provided in the discharge summary is used as a guide for the admission orders, be it from the pharmacy or the nursing home that the patient presents from. This is also very straightforward. You need to give the details of the prescription. So you list the medications the patient is currently taking and the ones that have been added during the admission. So you give the name, the type of medication, the mode of taking the medication and how often, and the duration. And that's it.
Hi everyone, so I'm going to continue with the referral letter part of our presentation. So referral of patients to hospitals, specialists, and other institutions is an essential component of primary healthcare. Patients are referred to specialists when investigation or therapeutic options are exhausted in primary healthcare, or when opinion or advice is needed from them. Referral has considerable implications for patients, the healthcare system, and healthcare costs. Good communication between primary and secondary care is essential for the smooth running of any healthcare system. Referral letters are sometimes the sole means of communication between doctors, and breakdown in communication could lead to poor continuity of care, delayed diagnoses, polypharmacy, increased litigation risk, and unnecessary retesting. as well as patient frustration and inaccurate information being relayed. Apart from conveying information, referral letters are a valuable source of reference, evidence of informed consent, and a medical legal record. Referral letters reflect the diagnostic skills, communication skills, and professionalism of the referring doctor. Studies of referral letters have reported that specialists are highly dissatisfied with their quality and content. Several studies have revealed frequent absence of an explanation for referral, proper medical history, clinical findings, test results, and details of prior treatment in referral letters. At the same time, clarity, legibility, and overall format are also important.
Is there a challenge with Talia only? Anyone else can hear me? Hello? You can hear me, all right.
Hello.
Hi, Prof. Sorry, it looks like we have load shedding. We're just going to connect to the data quickly.
All right, not a problem. Please let me know which name you're using. Is it Maria? And who I need to make co-host.
Prof, it'll still be Talia. We're just connecting to my data to make it work. Sorry.
No problem. Talia. Maria, let me know when you are on so that I can find Talia. I don't see a name still.
Sorry, Prof, we're busy logging on now.
Not a problem. Let me know when you are. Okay.
Prof, it's not letting me share my screen.
I've just shared now. You should see something prompting you. Talia? Yep.
Sorry about that. Okay, so to elaborate more on the key components of referral letters, the following are aspects to consider when constructing an adequate referral to a secondary or tertiary institution. So patient demographics, which include the patient's full name, date of birth, gender, ethnicity, ID number, full address and postal code, contact numbers, and relevant contacts, which include next of kin, their main carer, or emergency contact. In referring doctor's details, so this should include information such as their full name, their practice address, practice number, relevant contact details, and the date of referral. Referral destination, so the name of the receiving doctor and specialty clinic or department should be specified clearly, as well as the contact details of the receiving doctor or department and the hospital ward or unit number. Special requirements should also be clearly documented. So this could include information such as transport, for example, if an ambulance is needed with oxygen or if an incubator is required for a baby. And then other things like the patient's preferred language or if an interpreter is required. Presenting complaints. So you should list the health problems and issues experienced by the patient that has resulted in their need for current medical intervention. This could be in the form of either symptoms, for example, something like chest pain, or medical conditions which could be uncontrolled, exacerbations, or a new diagnosis, or events such as trauma, a response or lack of response to treatment, or abnormal investigation results. History of presenting complaint could include information such as onset, duration, severity, and relevant social, occupational, travel, or family history. Past medical history plays an important role in subsequent care. So it is important that the receiving doctor has an accurate summary of this information. This should include active medical conditions and relevant resolved complaints, and previous relevant procedures and investigations. Also try to document any allergies a patient has, including the type of reaction and when they experienced it. For management to date, you can accurately summarize the events that have occurred prior to referral. For example, referral to other relevant specialities, investigations, current treatment, which includes dosage and frequency, and if you have details of over-the-counter or traditional medicine taken, this should also be documented. And then reason for referral. So it's important for us to be clear about why this patient is being referred to secondary or tertiary care. For example, if it is for investigation, diagnosis, or treatment, and what the expected outcome is. In some cases, it may be reasonable to transfer full care of a patient to secondary care. And in other cases, the referral may be simply to gain a second opinion on the diagnosis, followed by management in primary care. Additionally, the type of care expected should be explicitly stated. For example, inpatient, outpatient, or emergency department care. In terms of urgency of referral, it should be made clear how quickly you expect this patient to be seen, whether it should be urgent, soon, or routine. If the referral is more urgent than routine, the reasoning for this should also be clearly documented. If an examination has been performed, all the relevant findings should be noted. Vital signs should all be documented, as well as all findings of the systemic examinations. If relevant, include calculated assessment scales, such as MMSE, activities of daily living, or life association, for example. And then clinical risk factors. So you should include risk factors that are associated with development of a medical condition that is being considered in the diagnosis. For example, smoking history for someone with suspected lung cancer, or sun exposure history for someone with suspected skin cancer, or industrial exposure for someone with suspected lung disease. In terms of investigation and results, you should document all relevant results. And if the results are not yet available, you should document the date they were requested, as well as the specimen reference code. In terms of safety alerts, there are several important points that should be covered if applicable, including the risk to self, for example, suicide, overdose, self-harm, or self-neglect, the risk to others in terms of risk to care professionals or third parties, and then consent to treatment. If a patient has been consented for investigation or treatment, this should be documented clearly. If an assessment of mental capacity has been undertaken, this should be documented, including who carried out the assessment, when the assessment was carried out, and the outcome of the assessment. If a best interest decision has been made because a patient lacks capacity, this should also be documented clearly. Advanced decisions about treatment. So if a patient has made advanced decisions about their treatment, for example, if they do not want to be resuscitated, this should be documented with the relevant signed documentation copies included as part of the referral. And then a lasting power of attorney is an individual who's been given the right to be involved in healthcare decisions on behalf of the patient if they lack capacity. So the details of this patient should be documented if required. So their name, contact details, and what role they've been assigned. We're now going to move on to a quick example of what an ideal referral letter should look like. So starting from the top, We have the urgency of referral as routine, referral to the plastic surgery and burns unit, so the specialty clinic, the address, the hospital unit or ward number and contact details, and then the patient details, so Mr. John Smith, the gender, date of birth, address, contact details, and then the patient's ID and next of kin. Referring practitioner details are also mentioned, so the name, address, and contact details. And then moving on to history of presenting complaints, examination, and investigation, which have all been put together. So Mr. Smith presented today with a 3-week history of a painful ulcerated lesion on his left external ear. The lesion is approximately 7 millimeters in size at its widest point. Patient reports bleeding initially, however, scar appears to have formed and discharge is not present. The lesion is raised slightly and appears to have an irregular border. Patient sleeps on his left side, causing possible irritation of the lesion and worsening discomfort. He has been advised to avoid this by changing his sleeping position. Patient is a frequent golfer and worked outdoors in the landscaping trade for around 30 years. A diagnosis of actinic keratosis was made 7 years prior. This history, combined with greater than average sun exposure, makes a diagnosis of basal cell carcinoma most likely. No investigations have been performed or requested. Reason for referral: I would appreciate if Mr. Smith could be assessed, the diagnosis of basal cell carcinoma confirmed, and the lesion excised if possible. Patient has been advised of this plan. Management to date: patient has been advised to sleep on his right side to avoid irritation to the left ear. No other management has been initiated. Past medical history, so they list the active conditions as well as the resolved conditions of the patient. And then no relevant family history, the current and recent medication, which contains the dosages as well as frequency of all medications. And they also list that no over-the-counter medications are taken, and there's been no recently discontinued or changed drugs. Clinical warnings and relevant risk factors. So the patient has an allergy to quinolones and penicillin, no BBVs known, or no risk factors present. The patient never smoked and consumes 2 to 3 glasses of wine per week. There's no relevant social history. And then under additional information, no patient transport or special access requirements, and the patient is aware of his likely diagnosis. This is then signed off by the referring doctor and dated. And that's all. Thank you. Thank you.
Thank you very much. Very useful. Great stuff. So I'm going to share with you very briefly a referral form that was created for, I'll just stop you from sharing. A referral form that was created for the various departments. So all of you are sitting in the hospital. You are sitting with a discharge form, which I've seen now, and one of the challenges is in terms of referral down to clinics. I'm not sure that this form has much value, although it was used by hospitals for a while. I'm not sure that you'll have seen in the hospital a down referral form from within the wards. Nonetheless, a key challenge has been for the doctors to know, that's you, for example, to know where you can refer in the Johannesburg area especially. And we created this little list of clinics which share exactly where the clinics are in which region, and which of them, by highlighting or sort of bolding them, which ones have got doctors in them. So this is just a way in which we as family physicians in the Johannesburg Health District have tried to support the writing of letters within the hospitals. It seems like a very useful set of issues that you've raised as a team on the patient referral letters to hospitals. And can I perhaps task you, as the team that presented, to look at creating a form, the hard copy form, that we could potentially use instead of the current form that's floating around in the public service. So if you can do that, that'll be really good. And we can then explore how the Department of Family Medicine could make that more formal. It seems like it has a lot of information, and I think that the electronic data gathering management of that seems like it makes it easier, but worth looking at. So can I leave that with you, Talia?
Yes, you can, Prof. We will do
Right.
that.
Well, it'll be really useful to leave something behind. I'm not sure that it'll work completely well because of the amount of information on one sheet, but we could explore it. Any questions, comments from anybody? I think we can close today a little earlier. I know that there was, the group that presented from last week would have had a discussion around the case that they shared. And I'm going to try and share it very briefly, but I think it's not going to share very well. So they presented two scenarios. This one, and they're asking the question, what important points need to be discussed when performing HIV counseling on this patient? Let's perhaps just stop there and ask that few questions, and I'm going to ask people to offer answers. So, or should I start pointing them out? Okay. Jason, do you want to offer an answer? Jason for Mark? And then Michelle Dandara, you can get ready to add to that. Jason, it was presented earlier. What sorts of ideas are important to deal with in the counseling of a patient? You've got a scenario already in the chat. 45-year-old Mrs. H attends the clinic for routine hypertension care. During the consultation, she's not tested since a pregnancy 10 years ago, admits no condoms, feels she's not at risk, but her husband demised 5 years ago and she's having relationships with the last one 6 months. Jason? Just unmute yourself and you can proceed. Michelle, go ahead while we wait for Jason.
Sorry, Prof. Can you please repeat the question?
Well, I've circulated in the chat a small scenario. It's not actually very useful. The scenario is not terribly relevant. The question is, what are the key issues that you need to deal with in HIV counseling? So it's really what we talked of earlier in the first session, just to see that you guys are listening and you've absorbed that. What would you think important? Just take a shot at it. I'm sure it's not, it's not rocket science. So Michelle, go ahead.
So with regards to Miss H, I would ask her if she knows the consequences of multiple short-term relationships and not whether or not she was using protection during those relationships. Okay. Since she's at a risk of not just getting STIs, but also HIV. Then I would ask if she and her current partner have been tested for HIV and if they're willing to be tested together.
Anything else?
So in my consultation with her, I would probably just do the pre-test counseling, informing her of all the ways in which she can get HIV, the consequences of testing negative or positive, and what she would need to do with regards to whichever results she gets. And from then on, after the test, then I would then see what her result is and go according to that.
Okay, remember what I said, you don't tell patients, you ask patients. So you'd be asking the patient, about what they understand by HIV. You'd be asking them what they understand about transmission of HIV and emphasize the need for condoms and other measures in which they can reduce their risk. You then would be wanting to know what she understands by treatment of HIV or the progression of disease, then the treatment of the disease. You would then have to ask her, what does she feel? How would she respond if she tested positive? Even if before you get there, I would establish what is her mental state. Has she got mental health issues? Was she sad, anxious? And whether she's had any suicidal ideation. You then would want to find out, well, does she know what the test is all about? In other words, what's the process of the test? She might have probably has done it before, but you ask, do you know what the test involves and what is done in the test? And she might tell you that quite quickly. Then you'd have to ask, well, tell me if it's positive, how would you respond? You could listen to it. Invariably, you want to know, well, who would they disclose to? Who would they look to support to? How would they manage support systems for themselves? And you'll have to accept what they tell you, but look at how you ameliorate some of that. People may say, I'm not going to tell anybody. I think when it gets to partners, you need to be very careful about the fact that they say, I won't reveal it, because you have an ethical obligation from SAMA guidelines to actually reveal it to that partner in a reasonable amount of time. So you need to be careful in that thinking. So those are the key issues that you need to be able to clarify. And then, of course, treatment. If they understand that what's involved in treatment, what's the difficulty in treatment, how they manage compliance, adherence, what do they know of side effects and the process of disease with treatment. So just listening, often you get lots of information very quickly. And then if they're negative, you want to try and talk to them about the window period, repeat testing, and then the kind of thing that you want to emphasize about prevention. So the group that presented, do you think there's anything else that you'd like to highlight for the team here so that they do get it clear? To me, those are the important elements, but
yeah, Prof, I think
Ishara.
you covered it really well. Yeah, I wanted, is it Michelle, whoever answered, that she saw that we were saying, or I was trying to allude to the fact that she sees sterilization, or rather condoms, as just to prevent pregnancy and kind of to emphasize that it's part of prevention of sexually transmitted infections and stuff like that. So I think it was all covered. Thank you.
Good. Thank you very much, guys. I'm going to stop there. The second scenario, just quickly look at it. It's, I think, raising the same issue I talked about earlier. It's about a partner who does not want to reveal a status to her partner. And I think the answer to that is simple. You can't force them, but you can tell them that you will give them time, but that you are ethically obliged to reveal it if she does not to her partner. That's why it's often important to tell patients that before they decide on the test, because they may refuse to do the test, which is their right. What you can offer them is to say, please come back with your partner and we can take up the conversation fresh. So you don't need to reveal that I told you to get it, but we can just say, let's just find a way to converse as if it's done straight off. So often patients, wives sometimes want their partners there and they want it to be new conversation, not them coming with the, with a message from the doctor. I'm positive, now you need to go test. They have all sorts of challenges with their husbands. So just getting their husbands in there, they hope that doctors will be able to mediate the kind of fallout that might occur. And these are some of the things I think have been raised in terms of thinking biopsychosocially, that you think about the psychosocial issues a little more, or listen for it very carefully and respond to it. So, a lot of the soft stuff in family medicine is not long time consuming. It's an attitude you have. If you think about it carefully and get it clarity in your head, you'll know you have to deal with certain issues. And these things pan out in a conversation, and they can happen quickly, especially if you learn how to stop talking and listen more and ask the right questions. And that's what a good family physician should be. So I hope you guys found that useful. Thank you all very much. You guys have done very well with the presentations. So it will be available on the website. And so tell your colleagues. I'll